Hi everybody, my name's Paul. I'm a licensed alcohol and drug counselor. We have that slide, didn't we? Okay. There we go. We're up and running. Welcome. Thank you all for being here. Today we're talking about pharmacology of today's marijuana. My name's Paul. I have a master's degree in addiction studies from Hazelden School of Addiction Studies, licensed alcohol and drug counselor in Minnesota and Nevada, and preferred provider for State of Nevada Nurses Association. I have experience in residential, intensive outpatient counseling, Hazelden Betty Ford Foundation, past LADC for university, and continuing education instructor, continue to do that for UNR. I'm a state certified intern supervisor, and I'm currently with Three Nations Tribal Center. But, you know, when I got into addiction studies and trying to help people, I came from the pharmaceutical industry, and I saw that with addiction, it was something that I thought that I could help out people real quickly, see a turnaround and help them become productive members of society and lead fulfilling lives. So my idea when I got into this was completely different than the actual reality. Just like my idea when I got into pharmaceutical sales was completely different than the reality. I'm doing a lot of talking about the opioid epidemic, and so it's either opioids or marijuana that everybody's interested at this point. And so with pharmaceuticals, when I started there, I thought, hey, I'm going to be partnering with a physician. I'm going to tell them all these great drugs that they can help people with. They're going to appreciate seeing me, and it's going to be a 1-2 punch. It's going to be great, and I'm going to be able to avoid 13 years of school and all of those student loans. And oh, isn't this a wonderful, wonderful idea? So I explained that to a doctor as I was leaving that industry, and he said, "Yeah, that was rather naive, wasn't it?" I guess it was. So with addiction. The addiction strikes first spiritually, then hits emotionally, then hits mentally, and then manifests physically. When it manifests physically, we have to get all that junk out of the person's system and start the healing process, which is exactly the opposite of the way that it's being impacted negatively. So you get that physical back first, and the physical is called detox. Then we get the mental back. The mind is resilient. Once you get the junk out of the person's system and they're able to remember what happened yesterday or the week before, they start getting real excited about recovery. Then emotionally, this is where we spend most of our time in addiction treatment. It's working with the anger issues, the depression, the anxiety, the relationships, all the life issues that come with no matter where you are in your stage of development. This is where we spend our time. And then spiritually, finally, and that manifests in the person's own conception of their higher power. It's not a religion or anything that we're pushing. So when I'm coming from the pharmaceutical industry, from what I perceived, from what I heard, it's kind of false compared to reality. When I look at my experience now from what I perceived or when I was going into it, it's not as accurate as reality. When we're talking about marijuana, we're going to try to look at reality, like what's going on here really. So we're going to review the active components, describe the delivery systems, and discuss data. So Nevada revised statutes, marijuana means all of the plant. So when they're talking about it, all of a sudden, you're talking about over 408 different compounds and 66 are termed cannabinoids. So they're talking about the whole plant. So when you hear marijuana, it's an umbrella term. But what's happening now is we're selling one actual component. That's THC. These cannabinoids are separated into the following subclasses. So because of time, we're going to talk about cannabidiol, CBD, and tetrahydrocannabinol, THC. THC, or delta-9 tetrahydrocannabinol, that's the marijuana's main psychoactive ingredient. Increases appetite and reduces nausea, may also reduce pain. When we say psychoactive ingredient, THC is actually the plant's natural pesticide. An animal will come up, it will munch on the plant, it will feel kind of weird, and it will say, you know what, I'm going to avoid that weed. I'm going to avoid that plant in the future. I'm going to remember this because it makes me feel weird. But you give it to a human being and they say, it makes you feel weird, give me more. CBD, cannabidiol, reduces negative effects of THC, has anti-inflammatory, anti-convulsant, antipsychotic, and analgesic processes. CBD is the most abundant of the cannabinoids. It makes up about 40% of the plant. Thought to have anti-anxiety effects, possibly counteracting the psychoactive effects of THC. And this is the stuff that you hear about for multiple sclerosis, fibromyalgia, epilepsy, and providing relief from chronic pain due to muscle spasticity, convulsions, and inflammation. So we look at THC and we recognize THC is a partial agonist to the CB receptor. The CB receptor, we're thinking that there's 3 different receptor sites. We'll get into that in a little bit. But that's one of the largest receptor sites that we have in the body. CBD, that's your antagonist. So here you got your yin and your yang. You get your balancing act. And so the even amounts of THC and CBD nullify the intoxicating effects. And CBD is being bred out of today's marijuana to intensify the intoxicating effects. So when you're going into a pot shop and you're checking out different marijuanas, they're telling you about how much THC is in there. You can get up to about 40%. Anything more than that, it's not going to be able to hold the consistency of the plant. And then you're getting more into the hash oil and to the dabs. So we look at delta-9 tetrahydrocannabinol, and we look at the chemical structure. So you see anandamide, that's the brain's natural chemical. That's created to be recycled. It's created to go fast and gently, delicately, make an impact, give its message, and then return back, be recycled. THC, on the other hand, is actually a lot more harsh and lasts a lot longer. So the messages are not getting just received, they're getting blanketed. So think about anandamide kind of as an electrical current when you flip on the switch to a light. You flip it on, there goes the light. THC is like the dimmer switch which will slow down everything and dim it for a considerable amount of time, depending on the amount of THC that the person's ingested. So here we go with the cannabinoid receptors. The receptors control appetite regulation, peripheral energy metabolism, pain and inflammation, GI motility, secretion, neuroinflammation. CB1 is found in the nervous system, connective tissues, gonads, glands, and organs. CB2 in the immune system. There we go. There's our cannabinoid receptors. And when we're looking at the cannabinoid receptors, look at the brain. It's tough to tell where one receptor ends and one begins. See those clusters up there? That's how everything is being regulated, or perception of these receptors are, whatever's being impacted is what's telling the person a message. So we saw a big receptor system, saw 480 compounds. We're looking at the different forms of delivery now. So this is, see how complicated everything can get really quickly? We're looking at smoking, we're looking at e-cigarettes, It can be vaporized, it can be added to food, brewed in tea or other beverages, and so we'll go through these different forms of delivery. But we'll start with smoking. So you take those 400 compounds of the marijuana plant, that becomes over 2,000 compounds when combusted. So we got 2,000 compounds going to these receptors in the CB1 and CB2s. So the smoking delivers toxins as well as potentially therapeutic compounds. This is why if you have 3 people smoking a joint, one can have the munchies and feel kind of giggly. The other one can feel kind of off balance and just zoning out. Are you picturing these people? And then the third one could be freaking paranoid, afraid the police are going to get them, afraid that their parents are going to find out. Why is that? It's because THC is impacting different parts of the person's brain. So we'll take a quick tour of the brain and we'll show what areas are producing what behaviors. So the neocortex, we know that prefrontal cortex area begins to mature around the age of 25. So when adolescents are being introduced to marijuana or today's marijuana and THC is impacting their brain, they don't have the executive functioning or a full mature stop sign to say this is not a good idea. So if it feels good, they go forward. So when we're in the healthcare professional role or we're in the parental role, we have to look at ourselves as surrogate prefrontal cortexes for those who are younger. We have to actually look out for these little people and make sure that they are not being impacted negatively or they're doing something that will impact their potential. Now, we look at the basal ganglia, and when I was working with students, my athletes were really interested in this area because this is reaction time. So when we're looking at reaction time, this is something that they are very interested in, especially if there's the potential to continue moving on or they're really engaged or they need their reaction time to keep that scholarship going. They're also interested in the cerebellum in the back over there. That not only takes care of emotion, but also balance. So balance and coordination. So when they come to me, say in the university, I had a lot of students who were coming to me wanting to get off of marijuana. And this was one of the tools that I used to let them recognize internally what impact they are making on different areas of their brain. And this was an effective way of having them choose to discontinue using. So let's go down to the nucleus accumbens. Here's a little troublemaker. Nucleus accumbens is what gives us that dopamine release. And the pleasure pathway has the ventral tegmental area, so that's not in this slide. It gives a signal to the nucleus accumbens. The nucleus accumbens says, hey, this is good. I'm going to give some dopamine to the prefrontal cortex. Prefrontal cortex is going to say, hey, let's go forward with this activity. It's good for our survival. It's good for us. Let's do it again. Hippocampus remembers it, and we continue with that action. So look at dopamine release. If you introduce food to somebody who's hungry, you get a score of about 50. So say you're cruising around 100, everything's doing okay, and you get an impact of 50. You say, hey, I'm going to remember that. That's good. I'm going to eat again. You get sex, that's around 2.25. That's the highest internal dopamine release we can achieve. That's for procreation. That's to keep our species going. You have dope or marijuana. You have alcohol. You have different drugs. You're starting around 300s. So would the person rather do one of those activities that give them a pure, natural dopamine release, or would you rather just get the dopamine release? Here's the thing. All of the stuff that has the natural dopamine releases take effort. It takes no effort when somebody gets high. So, and some of these numbers can go off the charts with high. Here's the problem. Now they have something to compare natural activity to. And they can obtain that dopamine release any time of the day, without any effort. The hypothalamus, that's for our friend who had the munchies. Amygdala, this is for a friend who is paranoid, who thought the police were after him. Now, you hear marijuana is good for PTSD. Okay. Let's see your study. How many people are in your study? What's the p-value? Is it valid or reliable? Oh, none of that stuff. I just know a veteran who smokes pot and he likes it. Well, your experience does not constitute a reliable and valid study. How about the veteran who smokes pot, that 2,000 chemicals turns into impacting the amygdala? Now we have somebody with PTSD whose amygdala is impacted and their prefrontal cortex is impacted. So we've actually started a chain of events with a panic mode, and we've actually made the person worse. So this is one of the things when we're taking a chance. One, you don't know what you're getting. You don't know where it's going. You can tell by the person's description or by their behaviors where it's impacting, but you won't know until it gets there. That's why when somebody smokes marijuana, you don't know where it's going. The hippocampus, this is for my artists and my musicians. They really like, we talk about how marijuana keeps them in the now, keeps them focused on what's going on. Well, that's good for the moment, but unfortunately, the hippocampus, as you know, is more of a filter, and it says what's not important, what's not important, what's not important. And so it tries to capture what is important, take a snapshot of it. Well, when the hippocampus is impacted with THC, it's saying nothing is really important except for what's in front of me becomes very novel. That's why TV is such a great babysitter. Now, if somebody's smoking, you want to test it, ask them to recite or read a couple pages and then recite what they just read. And it's not the best study aid because they're not going to remember. Brainstem, anti-nausea effects. Here's the thing with the brainstem. Remember back here, I was talking to an ER doc, and she said that the person was throwing up consistently, always throwing up. Like, whoa, what's going on? Well, she narrowed it down to marijuana use. What? I thought that was anti-nausea. She said she believed that too until the brain-gut connection was actually promoting a nauseous reflex. And so this was keeping that person throwing up. Spinal cord, the altered pain and sensitivity. Now remember, pain is not, and I go through this with my opioid talks, pain gets a bad rap. Remember the fifth vital sign? That sales technique that was very, very productive in selling OxyContin. Pain has a reason. Now, unproductive pain or chronic pain, there are ways to deal with that as opposed to just masking it. Because with opioids, the only answer is more. I'm finding the same thing with marijuana. If you have somebody who's smoking just the Mexican ragweed that took half a garbage bag to catch the headache, back in the 20 years ago or so, the answer there, if somebody's smoking consistently, is more THC, more potent, to get the same impact. Aspirin. Okay, so we're looking at marijuana. This is an offside kind of example, but when you're looking at marijuana, what they're saying really is like a person comes into the physician's office to say, you know what, I have a headache or I need my blood thin, and the doctor says, you know what, go into my orchard, chop down a willow tree, grind it up and start smoking. Because we know we get the aspirin from the bark of the willow tree, or a compound. So the person needs to sell their willow trees, so this is what they're willing to do to their patient population. That's as ridiculous as a lot of the arguments that I hear with marijuana. Okay, American Lung Association. There's a lot of lots of words on these slides. I'll go through it relatively quickly, but somebody was saying that it was good for, marijuana was good for cancer, and it helped them with their asthma. And it reminded me, remember back when with tobacco, with cigarettes were being smoked by physicians, and my physician smokes Camels, and Dr. Batty's asthma cigarettes. It reminded me of the Saturday Night Live skit. I don't know if you guys have seen this, but the one where kid comes into his dad and says, you know, I got a splinter in my hand, and the dad says, oh, put some butter on it. And then the kid comes in, he's got a scrape on his leg, and the dad says, oh, put some butter on it. And he keeps on getting more and more outrageous till the kid is actually lost his arm, and he has an artery that's spraying up blood, and the dad says, put some butter on it. That's the message that everyone is getting now about marijuana. It's if you have any kind of issue, any kind of problem, then smoke some marijuana. It'll take care of everything. Our obligation is to do no harm, or to at least look at the risk and benefit and have the benefit outweigh the risk when promoting a product to someone. American Lung Association, this is straight from their information. Smoke is harmful to lung health. It doesn't matter if it's tobacco or marijuana. You know, marijuana has more carcinogens in it than tobacco does. Tobacco is getting a bad rap. If you ask any of the younger people now about tobacco, they're like, oh, that's horrible, that's bad for you. How about marijuana? No, that's green, that's natural, that's not a problem at all. Do you know when the government, you know what decade the government linked cancer to tobacco? I hear the 60s, I hear the 50s sometimes, and it's the 20s, 1920s. It took all of that time to the 90s before the government said, you know what, we're going to shut you down unless you clean up your act. And so the tobacco industry said, okay, you know what, we're going to do that. We're going to put a little black box warning, and we're going to pay a $10 billion check, and we're going to actually change our name from Philip Morris to another name. And you know what, their tobacco sales throughout the world right now are better off than they've ever been before. If you think Microsoft brings in some big money, Microsoft and Coke and Starbucks, you take all three of those combined, you're not hitting as much money as the tobacco industry is hitting. In the third world countries, they're using the same ads that they used previously. And we can see the same script for marijuana. So it doesn't matter how the lung gets the carcinogen, as long as it gets it, we're introducing something negative to that person. Then look at how people smoke cigarettes, and then look at how people smoke marijuana. If you've ever seen that, it looks like they're going for the last breath of their life. I don't know who inhales more deeply, somebody who's suffocating or drowning, or somebody trying to get the next thing off of their pipe. Marijuana clearly damages the human lung. Regular use leads to chronic bronchitis and can cause an immune-compromised person to be more susceptible to lung infections. Both marijuana and tobacco and OxyContin do not build their businesses on the occasional user. They could care less about the person who uses a couple times a year. They want the addict. They need the addict to keep their business going. All the liquor stores, Not everybody who drinks is an alcoholic, and not everybody who smokes pot's going to be addicted to it. But the liquor stores only need 15% of heavy drinkers to keep their businesses going. So the answer a lot of the time is money. And that's why in Denver right now, there's more pot shops than McDonald's, Starbucks, and 7-Elevens combined. There's over 900 of these things. And that's just in the Denver area. No one should be exposed to secondhand marijuana smoke. So you got to watch who else is in here. Are there young people who are around the older people who are smoking or vaping? We'll get into vaping. Due to the risks it poses to lung health, so the ALA strongly cautions the public against smoking marijuana as well as tobacco products. More research is needed into the effects of marijuana on health, especially lung health. Medical marijuana should be subjected to the same FDA standards of efficacy and safety as any pharmaceutical agent promoted for purposes of alleviating the symptoms of disease. ALA supports research into the health effects of marijuana use, including the risks and any potential benefits of medical marijuana. See, here's the thing. If you have a chance, I know you all have your cell phones here. Think about cell phones, how these things have evolved, how communications evolved. I remember when we used to have a phone on the side of a wall in our living room that had one of those cords to it. And anybody could pick up that phone and we could say, "Get off the phone, I'm on the phone." Now, these little things are raising our children. This is the stuff that everybody gets their information from. This is the new way of communication. All of the advances that we're making, they're not bad. They're just different. We have to rein them in, let people know what is really a valid and reliable source. Because if you hit up smoking marijuana, you're going to have over 11 million hits. How can somebody actually get to an AMA white paper or ALA white paper or APA, AMA white papers when they're going through that tidal wave of information that's just inundated with them? By the way, here's all the references that I have from that last slide. Everything that I say, unless I preface it with my personal experience, is coming off of something that's researched. You're not going to find that with the emotional chat that you get from pro-marijuana people. It's always my experience where I know somebody. Medical marijuana card. Oh boy, this is mine. This is an insulting joke. I was talking to a physician in Denver, and she said it's an insulting joke on the medical industry. See, when you can take somebody's something that this is something we need to capture back. The people in the medical profession, in my mind, are arguably the most intelligent people in the world, but they're not very vocal. And so when somebody's trying to sell something and they hijack a name and they throw it on something that they're trying to promote, and they use this to fool a lot of people, it's insulting to the people who have earned this designation as a medical provider. You know, I go into a pot shop in Colorado, and I'm looking around, and the guy says, "Hey, can I help you?" And I say, "Well, I just want to really get high. What do you have for me?" And so he goes through all kinds of different kinds of highs. And so I'm going around, and I say, "Well, you know, my family wants to get high with me, and we're going to go up to the mountains. What do you suggest?" "Well, here you go." He takes me to another area, start showing me stuff, and say, "Well, my dog He's part of my family. I want my dog to feel like we do. Wow. He starts showing me some edibles. He did say, we don't really recommend it for animals because, you see, you can't prescribe this. This is not a prescribable medication. Anybody can recommend, and that's what they fall on, the little word changes, little play on words here. So this guy didn't ask if I had any kind of issues with my pulmonary system. He didn't ask if I had any mental health issues. He was just trying to sell me something, but in doing that, he didn't ask about the age of my kids. He didn't ask about just anything that a physician or medical provider would ask. He even was suggesting that I take something for my dog. That's where I drew the line. Don't mess with my dog. So, what do you need to do to write a prescription? For amoxicillin, you need to diagnose the person, you need their history, you need a physical, you need to review their systems. Then you have to decide what you're going to, for how long you're going to give them, the number of milligrams, number of refills. Dosing, diagnosis, risk assessment. What do you say to this person? This is how ridiculous this whole thing's getting. You take 2 joints a day. Inhale like this. Are you going to show them how to inhale deep? I want you to take this strain and hope this strain is still available. And I hope it's not been fertilized with too many toxins. So this is for the NRS Registry identification cards. So the division shall establish and maintain, this is Nevada. Nevada revised statutes. The division shall establish and maintain a program for the issuance of registry identification cards to persons who meet the requirements of this section. So, valid written documentation from the person's attending physician. So, you know, it's interesting when the young people are going to get their cards, they're not going to their family physician. Surprise, where are they going? They're going to that rubber stamp doc in the box who is making $60 every time he stamps a card and doesn't even see the patient a lot of the time. The person has been diagnosed with a chronic or debilitating medical condition. Average age for pot, is that in the 20s and 30s? Do they really have chronic or debilitating medical conditions? The medical use of marijuana may mitigate the symptoms or effects of that condition, and the attending physician has explained the possible risks and benefits of the medical use of marijuana. Here's the deal. So, Nevada law, approved conditions for medical marijuana. AIDS, well, we've had that. It's called Marinol. It's THC. It's already available through the FDA. It's regulated. It's monitored. It's for the AIDS scare that we had about 25 years ago. So it's available. So if somebody has AIDS and they want their medical marijuana, okay, well, try Marinol. Cancer. So you're introducing a carcinogen to help cancer. Glaucoma. Instead of taking eye drops to help that person with the high blood pressure, you're saying, I want you to smoke. Hey, Grandma, instead of taking these eye drops a couple times a day, I want you to smoke marijuana every few hours because marijuana's half-life is relatively short. So I want you to continue to smoke around the clock. Hey, it's 3 o'clock in the morning. Get up. You need to take a couple puffs to help your glaucoma. PTSD. We already talked about that. Seizures, we'll get into that, and the muscle spasms, cachexia, severe pain, additional conditions subject to approval by the Division of Public Behavioral Health. This is some basic recommendations, saying, is there documentation that the patient has failed on all other conventional medications to treat his or her ailment? Have you counseled the patient? documented by the patient, signed informed consent regarding the medical risks of the use of marijuana, at a minimum to include infection, pulmonary complications, suppression of immunity, impairment of driving skills, and habituation. Has the patient misused marijuana or other psychoactive and addictive drugs? Do you periodically provide drug testing? When I'm talking about this and opioids, people are drug testing. You're prescribing, say for opioids, you're prescribing it. So you take the example of the person who gets his 90 opioid pills at the end of the month, every month, comes in consistently, week after, or month after month after month for a couple of years. You do a drug test and you find out there's no opioids in that person's system. It's kind of odd to have somebody come in and get the same prescription consistently, because with opioids, the only answer is more. The only way to get feeling better is with that regimen of medication is more. Same with the THC with marijuana. So you want to make sure that you're drug testing. You want to make sure that you've reviewed exactly which patients should be allowed to use drug medicinally and for how long. So for how long, this goes with all medications whenever they're narcotics. Say, what does success look like? And let's define how long we're going to do this. When you have a contract with the patient and you say, you know what, after you take this for a certain amount of time, you should be feeling this. If you're not feeling it, we have to change the regimen. And we're looking forward to getting you off of this in a relatively short amount of time. We're going to use it as a tool, and we're not going to shy away from helping people. We're not into torture. But we want to use it as a tool, and we're going to make sure that they get the best therapeutic, optimal care that's possible. I'm going to do an aside. Methadone clinics, when I ask somebody about, well, what's your exit strategy? Oh, they got me on this for 5 years. Okay, that's an interesting exit strategy. Do you carefully examine and consistently follow up with the patients who smoke marijuana as a medical treatment, including pulmonary function testing? Yeah, you're introducing a pulmonary function issue now that you have to monitor. And you want to make sure that there's no superadded infection, especially with the fertilizers and the pesticides and all the chemicals that are used to make the plants grow as fast as they do. Now, they got this down to a science. So when you go into a grow, they have different lights that are using an awful lot of energy. Actually, they did a study. They saw that 1,200 grow houses in Denver were using as much energy as 35,000 homes. We're also looking, and that's keeping the fans going, keeping the lights going. We're also looking at a ton of water. This weed takes a ton of water. Have you exercised due care in ensuring the standardization of tetrahydrocannabinol potency content of marijuana to be considered for the medicinal use and whether it's free of microbial contaminants? Because marijuana is a federally controlled substance, have you set up a system that's established in the state to track all patients? Because right now it's federally illegal, which means that the pot shops is a cash business. They can't put the money in a bank that's federally, because the banks borrow money from the Federal Reserve Bank. It's not really in pharmacies. Can you imagine 900 pharmacies in this area? Go to Walmart and get your pot. Well, which strain are you getting? That's the first thing that I always ask when somebody says, wonderful thing about pot. It's like, okay, I believe it. It gets you high. But what strain are you using? And then keeping that strain consistent. Now, if it goes into a Schedule 2, here's something. The federal government is going to be regulating it. When the federal government regulates it, you're going to see a lot of pot shops that are starting to, they're going to have to wither and fold because they're not going to be able to be non-regulated anymore. And the regulation that the state is doing, you can see by the growth, the explosive growth, that it's not very effective. Have you shown knowledge, training, or certification in addiction medicine? Do you have demonstrable knowledge of the physiologic effects of marijuana, its side effects, and the interactions with other drugs before prescribing it? Then we have the interactions. Edibles. Here's the thing with edibles. You start with 10 milligram. That's what they say is the beginner dose. That's about a tenth of a candy bar or sixth of a cookie. Nobody really eats that. They eat the whole thing, but the problem is it takes 20 to 40 minutes to hit them. And with different types of marijuana, you're having different impacts in potency and different impacts in the time that it takes to reach that effect. Here's another thing. When an edible is eaten, it's metabolized through the liver. The liver adds 11-hydroxy to the delta-9 tetrahydrocannabinol. That's detected in the screening tools up to 5 weeks after ingestion. So if you're going for your DOT exam, they're checking for marijuana. Somebody was asking about what's the cutoff rate. So I was trying to look that up, but I'll tell you what, folks, that's a real complicated issue. If you get pulled over by the cops and you have marijuana in your system, that is complicated, and I don't feel confident in giving you a number. I'll put an asterisk by this. I heard 2 nanograms in the system, and that's about what I got. But you can't be reliant on that. You don't know when it's going to hit, how long it's going to stay in the system, or what the impact's going to be. All you know is that if you get caught, or if you don't have any kind of clearance and it's in your system, it's illegal. If you get caught in an accident and you have that in your system, that's going to be blamed. Here's another thing with edibles. With pot, if you get too high, you can always put it out. With metabolism, you can't stop it. And neither can your animals. This isn't the most responsible group when eating. Does this look like they'd be, like a kid would like this, or an animal would be attracted to this type of marketing? This is what's going out right now. These are edibles currently being sold. Well, if they're out there and your dog eats it, watch the veterinarian visits. If you have any friends in Colorado, I urge you to talk to your ER doctors. I urge you to talk to your veterinarian friends out there. They're going to let you know what's going on. I have some horror stories about dogs eating people's pot, and the uncontrollable shakes, the whimpering, the loss of their legs, the inability to move around. And this goes on for hours and hours because they're not set up to ingest all of the THC that's available. And that's what's being sold, is the THC. Dabs. Okay. What's happening is the isolation of CBD from THC isn't to take the CBD and give it to that kid who has seizures. It's not to help the person who has chronic pain. It's to get that away from the plant so that the person can get more high. This is a perfect example of this. This is THC at its best. We're looking at 90% THC. What do you think's going into the vape pens, folks? When you see those blasts of vapor, this is a perfect tool for them because they say you can't identify it. Here's the problem. When somebody smokes a cigarette, you can smell the smoke and get away. When those vape pens are coming around, you cannot, you don't even see it a lot of the time, but it's leaving a microfilm on everything that it touched. And you could see these big clouds of smoke going all over that you can't smell and you can't detect after they vaporize, but that's leaving a film that you can touch and you can get into your system. Yeah, it looks like honey or earwax. This is the stuff that is filling up the emergency rooms down in Colorado when somebody is shaking, screaming, kicking, has that sock over their face so that they're not spitting, it's because of this stuff. Looks pretty innocent, looks like jelly or peanut butter over at a carnival or a fair. All this stuff comes at us innocently. There's your vape pen. That's another thing that you're seeing on all kinds of street corners right now. I'm going to go through these relatively quickly because I want to get to some of your questions. So what happened when Colorado with medical marijuana dispensaries? You know, today there's more medical marijuana shops than McDonald's, 7-Eleven, Starbucks. Marinol, Dronabinol, we've already talked about that. That's synthetic delta-9 tetrahydrocannabinol. Indicated, it's been out for over a few decades. Anorexia associated with weight loss in patients with AIDS. Nausea and vomiting associated with cancer chemotherapy in patients who have failed to respond adequately. So this stuff's already available. Sativex, Epidiolex, this is an orphan drug for childhood epilepsy. Again, when people hear our veterans are hurting or a little kid's hurting, nobody's going to want to see that person suffer. Nobody wants to see that person tortured. Of course, everybody is going to, or most people, are going to want to help those people. The issue is, are we introducing them to more harm than good? And by introducing this, this type of chemical into their system. What's the dose? These are the things to consider. What dose do you give the person? What's the strain? How does this specific strain impact the body? People are growing and harvesting their own marijuana. What are they using to fertilize it? If you get a bad batch, does your drug dealer come and contact you and say, hey, you know that last batch of donkey stuff? Well, it seems like it's a bad batch. I'm going to have to ask you to come back in. We're doing a recall on that. No other prescription medication is smoked. Oh, I wonder what. Concerns remain about the long-term risk of respiratory problems associated with smoking marijuana. FDA, AMA, ASAM, SAMHSA, NIDA, all say the same thing. Separate the compounds, make the results reproducible, research in controlled safe studies to determine benefit to risk, be standardized by identity, purity, potency, and quality, provide directions for use, and include safe and reliable delivery systems. These are not unreasonable requests for a patient who's coming in to see a physician. This is not an unreasonable request for a physician to request that he gets this from or she gets this from the pharmaceutical company or whoever is selling this stuff. Again, not everybody who's going to smoke is going to become addicted, but in US, Canada, and Australia, it's estimated that 9% of people who try marijuana become dependent, and those beginning using the drug in their teens have approximately a 1 in 6 risk of developing marijuana dependence. I don't believe it. Marijuana is not addictive. Well, how do you know it's not addictive? I smoke it every day. Okay. So, marijuana is now the largest reason for treatment in adolescents. Now that's in Nevada. And when we're looking at marijuana use versus perception of risk, this is what it all is. Society saying tobacco bad, marijuana good, and the younger people are buying this up. This is marijuana use among the 12th graders. This is a prime time to get somebody addicted. Again, if you could get this person addicted now, then you've got a customer for life and somebody who's just going to want more and more potency. New Zealand study. Oh, wow. It doesn't impact my brain. Actually, it helps me. Look up, everybody has your phones. When you have a moment, look up NIDA, marijuana's lasting effects on the brain. This is 2,000 people in New Zealand. Call it the New Zealand study. 1,000 people they had for their control group didn't smoke marijuana. 1,000 people were smokers. For 25 years, they tracked these guys. Ages 13 years to 38 years. The marijuana smokers had 8 IQ points less than the non-smoking base group. Now, you can poke holes in all kinds of studies, and I can see some flaws here. But if we take the average IQ of 100 points, and we say, okay, well, they had 1,000 people and 8 points? Average. That means 50% is less than, even though your kid might be wonderful to you, might be average IQ-wise, maybe, when we look at that gross margin, 110 to 90, that's where a vast majority of the population is, in that 90 to 110. So, can they afford to lose 100 points? Now you hear President Obama said that he smoked pot, and Bill Gates said that he smoked pot. Well, if you have the support and staff that some politicians do, and they dabbled in it 30 years ago where it's nowhere near what they're comparing it to today, that's false. Or if you have an IQ of 150, like those little guys at the Davidson Academy, it's freaking brilliant. That's the stuff that we need to be concentrating on and promoting. It's more education, better education. But if we're promoting something that will actually take away 8 points, my question is, what about the kid that's not that bright? What about the other 50%? What about that kid in their developmental stages who is impacting their brain negatively at this time with this product? Here it is, Nevada treatment episode data set. Look at 12 to 17 years old. This is treatment admissions in Nevada. This is us. 43%. That's more than your alcohol, heroin, other opioids, or meth. 18 to 20 years old, you got 13. 21 to 25, that's 17%. Okay, what do we got there? 20, 60, almost 70%. That's everybody going to treatment. It's the young guys. This is the target market area. Go down to 50 to 55 years. You see 1%? Those are the guys who remember the good old days, and those are the guys who are selling this stuff. So when we're looking at the sales techniques, folks, they're working, and they're working right here. Go to rmhida.org. You can find out some information from the President's office, because we have somebody to compare it to. These are the 11 criteria for cannabis use disorder. That's the DSM-5. 2 to 3 of these will put you in a mild substance use disorder category. 4 to 5 is moderate, and 6 or more are severe. And treatment works. One of the things that I do when I'm working with, especially a younger person, is I ask them, take yourself out 5 years. Give yourself 5 years. So if they're 17 years old, now vision yourself as 22. And what do you look like? And what accomplishments have you had? And where are you in your life? Now you give yourself advice. You let yourself know what you have to do to make those dreams come true. So when you get the patient actually working with themselves and moving towards the vision of their core honesty and being consistent with their beliefs and values, they know the answer, as everybody else does. So when we're looking at this, hold on to your reputation as medical professionals. You're cherished and you're needed, and take it very seriously when anybody tries to insult your name. With that, if you know anybody who needs help, please have them see me. With treatment, I usually only work with them for 4 weeks, 5 weeks maximum. And with that, I hope I have a little bit of time for questions. Does anybody have any questions?
We do know that the hour's running short, so if you do have to leave, no offense taken. Whoa. I don't know what that was. Somebody else want to give it a shot? Anybody have any questions for Paul before we close it out for the day?
If you do have questions, please feel free to contact me. If I can't answer them here, I'd be happy to get back with you.
We do have one from Diana.
This one's not a question. This one is a thank you. That was a very nice evidence-based presentation and very much appreciated.
Thank you very much.
Yes, Paul, this is Dr. Schulte. Thank you very much. Very informative.
Appreciate it. Thank you.
You know, I didn't hit record on the video. Is there a way to get another copy of this if I need it?
Yeah, we do record it on our end. We're in transition on where we post them, but we usually make them publicly available.
Okay, how about just the slides?
The slides are online on our website.
Okay.
If you Google Echo Nevada, go to clinics, and then it will be under the special series clinic. Very easy to find, or I can email it to you if you'd like.
Okay, that would be great. This is my first time using this program, so I'll have to get a little more familiar with it. Again, thank you, Paul. Very, very good.
My pleasure. Thank you.
Can I get your email before you go off?
Sure, I'll put it on the little chat here.
Perfect. Thank you very much, everybody.